for developing intraventricular hemorrhage and other side effects. So with endotracheal epinephrine, limit the use, only use it when you're trying for UV access. In the DR or in the neonatal, when you're using epinephrine in the delivery room with a fluid-filled lung, I recommend using 0.1 mg per kg per dose at the higher end of the range mentioned. In the postnatal, when you're doing it in the NICU with an air-filled lung, consider using a lower dose because there is no lung liquid to dilute the epinephrine. And watch for heart rate, blood pressure, and possibly cerebral saturations, and monitor early ultrasound if you do use epinephrine in preterm babies. So going along, as I mentioned previously, that umbilical venous epinephrine is very effective. Here is umbilical venous epinephrine shown in orange circles. It's as good as epinephrine injected through the jugular vein, and it's very effective. And we have recently done a quick systematic review of studies done both in my group and also in Dr. Hooper's group at Monash in Melbourne. And we have put together all the data, and this is a very busy table, but I wanted to focus on two areas. One is the dose and the route at which it's given, and the incidence of recovery with the first dose of epinephrine. If you give a dose of 0.03, you'll end up with 83% recovery. If you give a dose of 0.02, you'll end up with 75% recovery, 0.01, 55%, and with endotracheal epinephrine, it's considerably lower than that. So it appears as though 0.02 and 0.03 milligrams per kg of epinephrine result in better ROSC compared to either 0.01 or endotracheal epinephrine. The second thing to think about is the amount of flush that we use. The current recommended volume of flush is 0.5 to 1 ml after giving epinephrine, and that is because the volume of the umbilical venous catheter is 6 ml. So the point of giving this much of flush is to flush the epinephrine outside the catheter into the portal vein. But if you have a baby who is in arrest, if the umbilical venous line is in the low UVC and this baby has no spontaneous cardiac activity and is being ventilated with high intrathoracic pressures, the likelihood of this epinephrine entering the circulation is fairly low when you use a low flush volume. On the other hand, if you use a slightly higher flush volume, it's possible that the epinephrine is flushed into the system and will be much more effective. Just to illustrate this point, here is a lamb in cardiac arrest where we injected contrast of approximately 1 ml with 30 seconds of chest compressions. And as you can see, the contrast just sits in the liver and is not really spread to the heart. On the other hand, when we give them a higher volume of flush, in this case it was 10 ml flush, the contrast spreads throughout the lung, causing much more even distribution. So based on this, we have used a dose of 0.03 milligrams per kg of epinephrine and studied different flush volumes, and 1 ml flush, 2.5 ml flush, and 10 ml flush in term lamb, which is flush, results in better return of spontaneous circulation with the first dose of epinephrine compared to the use of 1 ml flush. So using either 2.5 or 3 ml flush or 10 ml flush appears to be much more effective. And because of this reason, there are considerations right now as to whether we should standardize the dose of epinephrine. Instead of having a range of 0.01 milligrams per kg to 0.03 milligrams per kg, there is thought that we should all consider using a single dose when we initiate resuscitation, just to make the math simple. There have been instances where I have been in the delivery room and doing the math becomes very confusing. So there is more thought as to whether the initial dose should be 0.02 milligrams per kg, because at this particular dose, when the dose is 0.2 ml per kg, a small baby weighing 500 grams requires 0.1 ml, which you can easily measure with a 1 cc syringe. If you have a big baby weighing 4.5 kilograms, you can measure 0.9 ml, and that seems to be fairly effective. So there is thought to consider using a single dose of 0.2 ml per kg in these lambs. Similarly, for endotracheal epinephrine, there's a thought that in delivery room, you use 1 ml per kg or 0.1 mg per kg. And these are the considerations being considered by the NRP for the 8th edition. So to conclude, some of the practice changes that are being considered for the 8th edition that was recently put out at the NRP website by the American Heart Association. The thought is to use 0.1 mg per kg for endotracheal use in the delivery room and 0.02 mg per kg for umbilical venous use in the delivery room. And the flush, the plan is to increase the amount of flush from 1 ml to 3 ml for all weight ranges. I thank you for your attention, and here is my Twitter account and my email if you have any questions, and I hope I'm looking forward to Charles' talk and taking some questions after that.
Thank you very much, Dr. Sethi, and thank you so much for such a wonderful talk and review. I have the pleasure now of